All right, so medications I most often see dosed incorrectly. First on my list are blood thinners. Blood thinners are not good medications to dose incorrectly. If the dose is too low, then we're not adequately treating or preventing a clot, and if the dose is too high, then we're putting a patient at risk for bleeds. I've seen Eliquis dosed daily, and I've seen Xarelto dosed twice a day when it needs to be dosed daily. I've also seen patients not receive a loading dose after they've had a blood clot, like a DVT or a PE. After you have a blood clot like that, you're at high risk for another blood clot. So we have to lead with a higher starting dose. So we do 10 milligrams of Eliquis twice a day for a week, and then we do 5 milligrams twice a day for about 3 to 6 months, if not indefinitely, depending on if the clot was provoked or unprovoked. I've also seen patients on the 2.5 milligram dose of Eliquis for clot treatment. That's the wrong dose. So 2.5 milligrams is for patients who have, say, just had a hip or knee replacement and we need to prevent a blood clot. I'll also mention that patients who have AFib that we're trying to prevent a clot or like a stroke in, we have on 5 milligrams twice a day. But if they have like renal impairment, like kidney problems, like if their serum creatinine is greater than or equal to 1.5, and they're either greater than or equal to 80 years old or less than or equal to 60 kilograms, we do dose adjust it down to 2.5 milligrams twice a day. Same thing with end-stage renal disease patients on hemodialysis. I'll also mention that I've had a Lovenox patient get the treatment dose instead of the preventative dose. So the treatment dose of Lovenox is 1 milligram per kilogram twice a day or 1.5 milligrams per kilogram daily. The preventative dosing is 30 milligrams twice a day or 40 milligrams daily. That's preventative dosing. I'll mention that patients who are of higher weight do have higher prophylaxis or preventative dosing, depending on BMI. I've also seen a patient on warfarin and Lovenox just like for months on end, not just for like a bridge. That is also not appropriate. Another medication that I see most often dosed incorrectly are antibiotics. So providers I've seen will just dose like Keflex or amoxicillin just by weight and leave it at that, but they don't take into consideration the max milligrams per dose or max dose per day. So I've just seen them like super overdosed for patients, like 40 mils of like amoxicillin or Keflex like per dose. So I've had to call and clarify on those. So those are kind of interesting ones that I see. I've also had a patient who's a pediatric, very young patient get ceftonir for a pneumonia case, and then it was dosed incorrectly. You can dose the drug daily or twice a day, but in this patient, it was just dosed daily when it's supposed to be twice a day. So it's 14 milligrams per kilogram daily or 7 milligrams per kilogram twice a day. So I saw it as 7 milligrams per kilogram just dosed daily in this patient. So that's one I had to follow up on. And then I've also seen macrodantin, which is for a UTI dosed twice a day. Macrodantin is a 4-a-day medication. Providers will often confuse macrodantin with macrobid. So macrobid is twice a day. That's also important to make sure you're dosing that correctly so we're adequately treating the UTI. All right, so medications I most often see dosed incorrectly in the pharmacy part 2. So I will see titrated medications, like just titrated incorrectly. So one example is metformin. It's for diabetes, prediabetes, or PCOS. So it's supposed to be increased about like 500 milligrams per week, based if a patient is like tolerating it or not. So I've had a patient start out at 500 milligrams on day 1, and then 500 in the morning and evening, day 2, and then 1,000 in the morning and 500 in the evening, day 3, and then 1,000 twice a day on day 4. So they were escalated 500 milligrams every single day instead of a week. So I would expect a lot of GI upset with that patient, like nausea, diarrhea, stuff like that, if you just escalate it that quickly. I've also seen Lamictal dosed incorrectly. Lamictal or lamotrigine is a mood stabilizer. It's used in the treatment of bipolar depression. Then it's also used for seizure disorder. So if you escalate it too quickly, it puts a patient at risk for Stevens-Johnson syndrome and toxic epidermal necrolysis. So that's deadly. So we need to titrate it accordingly. So it's supposed to be 25 milligrams daily for 2 weeks, and then 50 daily for 2 weeks, and then 100 daily, and you go up like that. If someone's on valproic acid, which is an inhibitor, it is 25 milligrams like every other day, like starting out, and then 25 milligrams daily. And then it's also different if someone's on an inducer as well. More medications that I see dosed incorrectly are medications for my CKD patients or my chronic kidney disease patients. These are patients who have a decreased renal functioning, a decreased kidney functioning, so they're not clearing toxins and drugs as well. These patients are at a high risk for drug toxicity with medications that need to be like renally dose adjusted, for example. One example is ciprofloxacin. It's a particularly toxic antibiotic. It has a lot of black box warnings like tendon rupture, peripheral neuropathy, seizures, just a bunch of issues. It needs to be dosed down in patients who have CKD3 or 4 or on hemodialysis. Another medication that is also kind of toxic is baclofen. That also needs to be renally dose adjusted down. I have had a patient who was on dialysis receive too high a dose and was hospitalized after getting baclofen. It was already dose adjusted, but I noticed that it wasn't dose adjusted enough, and I held the medicine, but another pharmacist filled it when I wasn't there. Another medication is Lovenox that I talked about in my last video, blood thinner. It needs to be dose adjusted in CKD patients, creatinine clearance less than 30. Another medication is Januvia. It's for diabetes. It's a DPP-4 inhibitor. Another medication, Crestor, that I've caught in a dialysis patient where the dose is too high and she's experiencing an intense amount of muscle pain or myalgia. Another medication is colchicine that I've caught in a patient who was on hemodialysis who should not have been on it. This was in the hospital, actually, and they were giving it to them daily because it was on their med list. I will mention that colchicine will kill you in toxicity, and it's not cleared by dialysis. So more medications that I see dosed incorrectly are medications that people are on that interact with like Paxlovid or enzyme inhibitors or inducers. So most often these are medications like Eliquis or Xarelto. I've seen cyclosporin dosed incorrectly and atorvastatin, Cialis. These are some medications that I've caught in patients who get prescribed Paxlovid that we either need to hold the medicine or dose adjust it.
So medications I most often see dosed incorrectly, part 3. First, we have the EpiPen auto-injector. Remember, we give this with anaphylaxis. It's injected into the outer thigh. You can give a second dose after 5 to 15 minutes if symptoms persist. And then remember, call 911. The dose, if you're greater than 66 pounds, is 0.3 milligrams. If you're less than 66 pounds, it's 0.15 milligrams. And we even have a dose for patients less than 33 pounds, which is 0.10. It's branded as the AVQ. I can't tell you how many prescriptions I've seen for a 0.15 EpiPen in like an adult person who is obviously greater than 66 pounds. Next, we have vitamin D 50,000 units. We give this to patients weekly for a few weeks if they're vitamin D deficient. I've seen a handful of prescriptions come through for this dose daily, like quantity 30 with a ton of refills, like 50,000 units every single day for months. I will mention that some medications warrant higher dosing, like with hypoparathyroidism, rickets, or familial hypophosphatemia. But for your general, like run-of-the-mill vitamin D deficiency, you're gonna wanna dose it weekly for a few weeks. My brother, who's a family med physician, actually called me the other day. He had a patient who he gave 8 capsules to, and it said on the bottle, like, take it weekly for 8 weeks, and he took it every single day for 8 days. And my brother was like, what's gonna happen? Like, is this a bad thing? And I was like telling him like it would be probably fine. It would be more of like a deal if it was like every single day for like a few months. That's when I would expect something like hypercalcemia or maybe some like toxicity. Next on my list, I have GLPs like your Ozempic, Wegovy, Mounjaro, Trulicity, all that good stuff. I don't know why, but I see these medications like incorrectly titrated sometimes. Like, so patients are starting out like 0.5 milligram Ozempic instead of the 0.25 milligram or the 1.5 Trulicity and not the 0.75 Trulicity. What I also see with the GLPs is being like restarted at the like same dose that they were on after like months of not using it or like a back order. So like I'll have a lot of patients who are on like the 2 milligram Ozempic and they're like stabilized on that, and then like they'll go like 5-6 months without the medication because of the back order, like their insurance isn't covering it, and then they'll just be restarted at the 2 milligram after like months of not using it. Granted, we don't have any like guidelines telling us how to switch between GLPs or how to reinitiate them after someone's been off of it for a while, but like using clinical judgment, I don't think I would reinitiate someone at like the max dose of Ozempic after they've been off of it for 5 to 6 months. I would start at a lower dose, or else they're going to be like really nauseous because their body's going to adapt to not like using the medication anymore. More with the GLPs is I'll see providers like switch between them and like incorrectly like dose adjust it, or I guess I'll say like dose adjust it. When Zepbound came out, I had a lot of patients switch from Mounjaro to Zepbound. So I had like a patient who was on the 7.5 Mounjaro and the provider switched him to the 5 milligram Zepbound, even though they're the exact same medication, tirzepatide. So they should have been switched from 7.5 Mounjaro to 7.5 Zepbound, but they got a dose decrease. I think the provider was thinking that they're like different medications and they're doing some sort of like incomplete cross tolerance thing. But lastly, with the GLPs, I had a prescription for Ozempic come in, injected like twice a week. So that was a first for me. Twice a week instead of weekly. It's interesting. Medications I most often see dosed or like used incorrectly, part 4. Topical steroids. This is your hydrocortisone. Over the counter comes as 1%. Behind the counter comes higher, like 2.5%. This is your betamethasone, your halobetasol. Fluticasone comes as a topical. Mometasone, desonide, fluocinolone. FYI, some two really potent steroids are clobetasol and halobetasol. Fun fact, steroid ointments are more potent than creams. So topical steroids, we use it for like psoriasis and eczema. You're supposed to use it up to 2 weeks, maybe even up to 4 weeks. This has got to be like some dermatologists like Roman Empire. But using it longer than that, like say like every single day for months, up to like a year and years plus, that can lead to topical steroid withdrawal symptoms, which can be pretty brutal. You can Google it if you're interested. Burning, stinging, redness on the skin can be some symptoms of like withdrawal or overuse. I have a lot of patients that like routinely fill this stuff, and like a lot of caregivers even getting like the tub, the pound, the 454 gram tub of like cream and ointment, and they keep coming back like every month, every 3 months for it. Like some y'all having a bath in this stuff. I will mention that some patients can get some like systemic side effects with the higher potency corticosteroids. It isn't super common with the lower potency. But next we have albuterol as a maintenance inhaler. I've mentioned it on my page before, but we use albuterol as like rescue therapy for having an exacerbation, or maybe even before exercise. If you're using an albuterol inhaler multiple times a week or multiple times a day, this tells me that your symptoms are poorly controlled. GINA guidelines for asthma changed a couple years ago. It's now preferred to use something like Symbicort or Dulera as like smart therapy, single maintenance and reliever therapy. But I do have some patients filling their albuterol inhaler every like 2 or 4 weeks, and sometimes their insurance isn't covering it and they pay out of pocket for it. This is kind of when I start to say something. I also see some of my COPD patients using albuterol all the time. They should be on something probably like a LAMA or a LABA or LAMA-LABA combo. I know that sounds like gibberish, but it's a long-acting muscarinic antagonist or a long-acting beta agonist. So something like Incruz or Spiriva or a Noro, or if it's real bad, something like Trelegy or Breztri. The gold COPD guidelines actually just changed a little bit ago too. So depending on your symptoms and exacerbations will put you in a certain group. So if you've had an exacerbation that's resulted in a hospital administration, or if you've had like 2 or more moderate exacerbations, you're already plopped into group E, which is a LAMA-LABA combo. Then we add an ICS if you have elevated eosinophils. But random little side note, using a lot of albuterol can increase your heart rate, cause tremors, and then also can lower your potassium. Another dosing mistake that I see all the time is metoprolol tartrate and succinate being like dosed incorrectly. So tartrate is twice a day and then succinate is daily. So I'll see like metoprolol tartrate dosed daily, and I'll see metoprolol succinate dosed twice a day. Lastly, I'll mention your triptans. This is like your Imitrex, sumatriptan, your rizatriptan. These medications are used for the acute treatment of migraines. If you're having more than like 4 migraines a month, it might be appropriate to consider prophylactic therapy or preventative therapy. I do have like a couple patients that are using like Imitrex like every single day. This tells me that their migraines are poorly controlled. Some preventative options are like the Valproex, topiramate, some beta blockers like propranolol. Another oral preventative option is the calcitonin gene-related peptide receptor antagonist rimegepant or Nurtec. This is taken every other day, but it can be expensive. My favorite preventative therapy are actually the CGRP mAbs, or the monoclonal antibodies. So we have Emgality and Ajovy blocking the peptide, and we have Aimovig blocking the receptor. These medications are usually injected subcutaneously monthly. Ajovy actually has a version where you can do 3 syringes at once every 3 months. I will mention that Emgality, for the first dose, you have a loading dose. So 2 120 milligram syringes, which is 240 milligrams, and then 120 milligrams monthly. And then for cluster headaches, 3 100 milligram syringes every month until the cluster period ends. Aimovig can be dosed at 70 milligrams or 140 milligrams monthly. And lastly, I mentioned eptinezumab or Vyepti. This was FDA approved in 2020, and it's the first IV infusion CGRP for the prevention of migraines. It's administered over 30 minutes, and this is done every 3 months.